Good morning, everyone. I would like to thank Rajesh sir for giving me the opportunity. So I'll be talking on OCT in glaucoma. Since the structural abnormalities precede the functional changes, imperative to have an objective, quantitative, and reproducible technique will help in the early diagnosis and monitoring of the disease. OCT has transitioned from time domain to spectral domain and now to swept source OCT. It works on the principle of Michelson's interferometry. An incident wave is divided into two. One part is projected onto the reference mirror and the other goes to ocular structures. These two waves are reflected back and taken up by an interferometer, which measures the coherence between the two and thus calculate the thickness of the various ocular structures. With the time domain OCT, scanning and processing time is long, axial and lateral resolutions were low. But the spectral domain OCT provides increased scan speed, higher and better resolution, and greater reproducibility. The latest edition swept source OCT provides extended depth imaging with increased scan speed. However, the axial resolution is same as that of the spectral domain OCT. So with this, I'll be moving on to the interpretation of the scans with the help of Cirrus printouts. Cirrus provides the optic nerve head and the RNFL analysis in the same printout. So this is the printout, and zone 1 is the patient details. Age of the patient is very important as the measurements are compared with the patient's compared with the normative database. Any wrong entry of the patient details will make the machine to take it as a new entry in the subsequent scans, and it may not be taken up for the progression analysis. Then zone 2 is the quality of the image, which is expressed as signal strength, and it should be more than 6 for the Cirrus OCT. Zone 3 is the segmentation tomogram. You have a horizontal and vertical tomogram for the optic nerve head and a circular tomogram for the RNFL. Before going into interpretation of the scans further, you have to look for any segmentation error. Zone 4 is the RNFL thickness map. Normally, it appears as an hourglass pattern of red and yellow color on both sides of the optic nerve head. Zone 5 is the RNFL deviation map. It has an end-phase fundus image and also shows the margins of the cup, margin of the disc, and the calculation circle for the nerve fiber layer measurement, which is 3.4 millimeter from the center of the optic nerve head. Zone 6 is the optic nerve head and RNFL parameters. This is color-coded with respect to the age mass normative database in the machine. The thinnest 1% values of the normative database is marked as red, that is outside normal limits. 1% to 5%, including 5%, will be yellow, that is borderline. More than 5% to 95% will be green. More than 95% will be white. If the values are not compared with the normative database, it is shaded as gray color. If the area of the optic disc is less than 1.3 or more than 2.5 millimeters square, it is outside the scope of the normative database, and this is also shown as gray. Normative database is, if not available for age less than 18 years. Zone 7 is the Tisnit curve for the neuroretinal rim. Here, the continuous line is for the right eye and the dotted line is for the left eye. If the graph falls within the green area, it is within normal limits. Yellow will be borderline and the red will be abnormal. Zone 8 is the Tisnit curve for the RNFL. Usually, it has a double hump pattern because of the increased RNFL thickness in both superior and inferior quadrant. Zone 9 is the quadrant and clock hour average RNFL thickness. So now coming to the macular ganglion cell analysis, cirrus gives the combined thickness of the GCL and inner plexiform layer. Here again, zone 1 is patient details, zone 2 is the signal strength, zone 3 is the horizontal tomogram for the segmentation, zone 4 is the thickness map, zone 5 deviation map, zone 6 is the sectoral thickness, zone 7 average and minimal thickness. Here again, zone 5, 6 and 7 are color coded as I described earlier. Now we'll move on to the guided progression analysis. This is the printout. Again, zone 1 patient data, zone 2 signal strength, zone 3 gives the baseline and the follow-up examinations with date, quality of the serial scans and the average RNFL thickness. Here the initial 2 scans are taken as the baseline and the rest of the scans are the follow-up scans. It shows RNFL thickness map and the deviation map. This is again color coded as likely loss, possible loss and the possible increase in the thickness. Zone 4 is the trend analysis which is plotted over time and it is available for average RNFL thickness, superior RNFL thickness, inferior RNFL thickness and average cup to disc ratio. Zone 5 is the Tisnit, it is an event analysis which shows the Tisnit current Tisnit curve with the baseline. Zone 6 is the ONH and RNFL summary which is again color coded. It also gives parametric projection, that is the numerical value of RNFL and the optic nerve parameters of all the examinations done, which is again color coded. With advanced loss, RNFL thickness levels rarely falls below 50 and never below 40 due to presence of residual glial or non-neural tissue, which is known as floor effect. Coming to the source of error, it can be divided as patient and disease dependent, operator dependent, and device dependent. Pupil diameter is usually not affected by the current SD OCT scans, but if you get any artifact with the normal pupil size, better to dilate. Blink causes transient loss of the data. So ask the patient to blink physiologically during just before the acquisition of the scan. Dry eye or cataract will cause reduction in the signal strength and cause RNFL thinning. Floaters or vitreous opacities, if they fall within the scan area, it can affect the measurements. Motion artifacts are seen on the end face image as the vessel breakups or horizontal shift. Segmentation errors occurs due to high myopia or presence of shadowing artifacts, dense optical membrane or traction bands, etc. Peripapillary atrophy causes the thinning of the RNFL and myelinated nerve fiber causes RNFL thickening. Red disease occurs when an OCT mistakenly identifies an area or eye as abnormal when actually there is no disease. It happens in extreme myopia. Green disease occurs when an OCT data shows no signs of abnormality in presence of disease. Here actually all the values are in green, but if you look at the Tisnit curve, you can make out the localized dip. Operator dependent errors occurs due to improper image acquisition as in this scan and decentration of the scan. Here the scan circle is closer to the optic disc superiorly, so it will give rise to RNFL thickening and here lead to RNFL thinning. Device related errors due to absence of eye tracking, segmentation software or improper database. Swepso's OCT provides enhanced depth imaging and analysis of the choroid and the lamina cribrosa in addition to RNFL and macula. OCT angiography provides repeatable high-resolution evaluation of the various retinal vascular abnormalities. We will quickly move on to the anterior segment OCT. It is rapid non-contact anterior segment imaging with the patient in the upright posture. So we look at the uses in glaucoma. It helps in the measurement of various anterior segment parameters. You can measure the central corneal thickness, anterior chamber depth, that is from the corneal endothelium to the anterior surface of the lens. Lens vault is the perpendicular distance between the anterior pole of the lens and the horizontal line between the scleral spur. Various angle parameters are also possible to measure. The important anatomical landmark is the scleral spur angle opening distance is at 500 micron is the perpendicular from the inner corneoscleral wall to the anterior surface of the iris at 500 micron from the scleral spur. Also, you can measure the trabecular iris space area. It is a trapezoid area. Anteriorly, angle opening distance, here the iris surface, and here inner corneoscleral wall, and the perpendicular from the scleral spur to the anterior iris surface. Also, you can measure angle recess area, iris thickness, scleral thickness, etc. You can qualitatively and quantitatively analyze the narrow angle. Check the patency of the laser peripheral iridotomy. Here in the second image, even though the transillumination was positive, PI was partially obstructed with a narrow band of iris tissue. You can assess the morphology of the filtering blur, check the patency of glaucoma drainage device. And the advantage of AS-OCT over UBM include its non-contact, high axial resolution, faster acquisition time, wider field of view. It can be possible in the upright position, but the drawback is limited ability to visualize the structures posterior to the iris pigment epithelium. Thank you.